I just want to say hi to everyone and welcome to our second live call here in the GetExpanded community. I'm JP. I'm the co-founder of GetExpanded.org alongside Patrick, and I appreciate all of you guys for joining us tonight. And if this is your first time here, I just want to introduce us. GetExpanded, we're a global platform and community focused on airway health and airway orthodontics. And really our mission is just to bridge that gap between patients and professionals. That way we can have open-minded conversations. And yeah, tonight we're really excited to have Dr. Jeremy Manuele, also known as Dr. J. This is his second call with us. And many of you guys might know him. And if you don't, he's an airway orthodontist in Vegas. And he also treats patients online. And he's also the author of the book, The MARPE Advantage. And yeah, tonight's topic is going to be on unwanted fractures during expansion. And I think it's really crucial for both of us as patients and providers to get a real understanding of why these fractures are really happening and how we can prevent them. And yeah, and as always, we're going to have time for a Q&A at the end of the call. So if you guys have any questions, feel free to post them in the chat and then we'll go through them one by one in the end. And with everything said, let's get started. So Dr. Jeremy Manuele, thank you again for being here, and yeah, the floor is yours.
Awesome. Thanks, JP. Glad to be here, and hopefully we got all of our AV stuff worked out. If you're hearing a crazy echo or anything like that, let us know. But yeah, so excited to be here, excited to talk to you guys a little bit about fractures. Sometimes, these are the things that we don't like to cover, that we don't like to talk about, that sometimes we like to dig our head in the sand and ignore. But certainly it's valuable to explore, of course, not only the things that can go right, but the things that can go wrong, and more specifically, what we can do possibly to avoid these things and or correct them if they happen. And from a patient standpoint, it's really nice to know some of the signs that you might be able to see as a patient if you may be starting to experience one of these complications. And so this, if you guys haven't seen it before, this kind of was a case that was posted on Reddit quite some time ago. And when people first saw this, it was quite alarming. So other patients and practitioners alike, because there was obviously some sort of change that had happened, and they weren't really sure why that had happened or what had happened. And so they were throwing this out there as kind of a question, like, what should I do about this? And so, like many of you, if this is your first time seeing it, might have been like many of us practitioners when we first saw this, we're like, whoa, this is not good. Like, what's going on here? And so obviously we need to make sure that we understand what's happening with expansion, but rather than run away or be afraid of things like this, it's going to be much more valuable to all of us if we can really pinpoint and understand not only what is happening, but also why this is happening. And I don't know this patient personally. I mean, I have only seen her online, just like you guys. But there are a lot of possible MARPE complications. And of course, we're not going to go through all of them tonight. We're going to be focusing on fractures. But, in the beginning, when we started to experience complications, it was like, patient one of one. And we had to, figure out and learn, well, why did it happen? What can we do to prevent it? But now that MARPE's been around for so long and the techniques have been revised and improved and the appliances themselves have been improved, we experience so many less complications than we ever used to. And so let's go through unfavorable fracture today. And the first thing I want to point out is, why we have fractures and where those fractures typically occur. So as you can see, the green bone here is the maxilla. This is what we're trying to divide with MARPE. And you can see here that these two bones are even demonstrated on this magnetic skull model. You can see the split between the two halves of the upper jaw. And as you may know, as we grow as kids, these two bones are distinct and separate, and they each grow. And as they do, the upper jaw as a whole gets wider. And then once you finish your growth, what happens is that there is what they call a maturation of this division, and these divisions are called sutures. And so what happens is there's a maturation to where no longer is this suture super active like it is during growth. but it is more stable. And the stability of this suture is different depending on a lot of things. And we don't even understand all the things it depends on it. But what we do know is that there are different classifications for how much these sutures mature, meaning that some people's sutures really, really bind tightly after growth is done, and they're more difficult to spread apart. And other people's sutures really don't. They are interwoven and they're stable, but they're very easy to separate. Sometimes we can get a hint radiographically looking at x-rays, which type of suture you have. One of the things that I offer as I consult with patients and are reviewing their images is a glance at this midline suture to determine, and it's not 100%, but it's like, am I more or less likely to expand? Am I more or less likely to want to consider a piezotome or a piezo-osteotomy? These are things that we can look at the x-ray and cross-section and kind of get an idea. So if you'll notice here, not only is there this kind of division on this magnet skull model, you'll notice there's these other kind of divisions as well that separate these different colored bones. And it's important because not every suture is exactly the same, but they often operate in similar ways, meaning that while you're growing, they're active and changes can happen very easily at these sutures. And then once you're done growing, they are no longer active. And there's some form of stability that happens. And just like this midline suture here, other sutures can be more or less predisposed to coming apart. And when a suture comes apart, that's what we're terming as an unfavorable fracture or a fracture, if that makes sense. So when the midline splits, we call that a fracture. The jaw is split, it's opened. And if one of these other sutures splits, that would also be an example of being open or fracturing. So here is a view at looking at these sutures that are most important. And we're going to talk primarily about this suture here. And this is the maxilla and this is the palatine bone. And we'll take a closer look at that later. So we're going to talk about this suture here that goes across, and we're going to talk about this suture here. And these are two of the most common places for unwanted fractures. You can have fractures at some of these other sutures, but most commonly we see them here. And then maybe second most commonly would be this one back here. And we'll go through why that happens. But before we do, I want to have you think about the question, like, why don't we experience these fractures when we do expansion in kids? And so I personally have never seen a sutural fracture, unwanted fracture in a child expansion, in a teenager expansion. So this is most exclusively an adult problem, or rather a non-growing patient problem. And the answer is that it goes back to what we talked about. When these sutures are mobile, and when you're growing and when there's activity happening here, they don't have to fracture. They have the ability to bend and to move. And so that's what they do. Even if you put too much force, they just tend to remodel rather than break. And, is it possible to have a suture in a child or teenager break? Yes, it is. But you would have to put a very, very extreme amount of force on those sutures in order for them to break. So if we kind of use reverse logic here, well, if kids' sutures don't break very much, then what can we do to make non-growing patients or adults to make their sutures not break so much? And that's the question that we are continuing to ask to this day. So one of the things that is a little bit newer in our space is, how much does the way that you turn your expander matter when it comes to the activity or the effect that it will have on the sutures? So when I first heard about what's called FCPC, or force-controlled polycyclic cycling, I was curious, and I saw it in some medical literature, in our dental literature, and they were showing some cases where they were using essentially less TADs and not connecting to the teeth, but they were still able to get sutural splits in cases that otherwise would have seemed fairly difficult. And so that was sort of what piqued my curiosity. I'm like, wow, okay, I wouldn't have expected that jaw to open up with that many TADs in those locations, kind of thing. And so I researched this protocol, and it was actually invented over in Europe. And so what they do is in Europe, it's very popular to have MARPEs that don't have any anchorage to the teeth. Essentially, they kind of use a different protocol than what most of us use here in the States. So what they'll do is they'll go in and they'll actually place TADs, the temporary mini implants, into the palate, and then they will scan the palate and the teeth, and then they will send out to have these expanders made based on where they placed the TADs in the palate, and then the expander will come back and they will put the expander over those TADs. Whereas we here tend to do everything guided in advance. So we send out x-rays and we have these expanders designed which have lumens which direct the TADs to the positions that we want them. And then we place the expander first, and then the TADs kind of secure the expander onto the palate. So once I started to see what they were able to do with, seemingly less TADs on seemingly difficult cases to expand, I started to experiment with this protocol myself. And I did do a YouTube video on this if you want to have like a more deep dive into what exactly this is. And if you look at the protocol as it was initially written, it is fairly complex and it is somewhat difficult to implement into a busy private practice. And so the protocol that I use for turning now is a somewhat simplified version of this. So when they originally did this protocol, you can look it up yourselves. The original research articles are linked in this video also. But when the original protocol calls for an actual force gauge, and that force gauge was calibrated to a tiger screw type of device so that when you put it on there, you can measure the force. And the idea is you do these forward turns, you let the expander sit, then you do backward turns, what I now term stretching turns. And what those stretching turns are designed to do is loosen up these sutures, and more specifically, this midline suture. So the design of the protocol was really just to more predictably get a split of the midline suture. And sometimes they would even stop the force-controlled cycling turning protocol once they got that split. But now what we're finding is that not only is a cyclical turning force good to initially get this midline split in the palate where we want it, but it's also good to keep mobility at these other sutures, meaning to keep these joints loose or these sutures loose more like they are when you're a kid, so that as you continue to expand, you are less likely to have one of these areas break and more likely to have them bend or remodel. And so that's the basic premise of what we're trying to do now in order to prevent this. So my current turning protocol, I'll have patients do two types of turns. One type is stretching turns, and the stretching turn is essentially turning the expander forward a certain number of turns, letting it sit, and then turning the expander backward that same number of turns. And so we'll usually start out with 2 or 3 forward turns. And you'll see, that's quite a bit of pressure. And as you do these stretching turns, though, you'll notice that you may be able to do more and more of them as the maxilla loosens up. So you might, a week later be able to do 4 forward turns and then 4 backward turns, and then maybe 5. I'll have my patients go all the way up to 6 forward turns, hold it, and then 6 backward turns. And when you're doing those stretching turns, what you'll notice is that the forward turns become very easy. And so if it really is kind of a nuanced and tailored turning protocol, because if ever the stretching turns get too tight or the forward turns get too tight, you basically just pause the forward turns and continue with the stretching turns until things are loosened up again. And so going back to these unwanted fractures, so let's see if we don't have enough mobility, what happens and how we detect that. So this is something called a frontomaxillary or a nasomaxillary or a frontonasal maxillary suture fracture. And all that is saying is just describing the bones that are involved. So the frontal bone and the maxillary bone, or the nasal bone and the maxillary bone, or all 3 bones. And what we tend to see in the mouth is this, and this is what you guys as patients are going to want to be looking for. So if you notice a sizable step in the vertical dimension of the front teeth during your expansion, that may be a sign of a fracture. Now, this is not the only thing that can cause a discrepancy between the vertical height of your teeth, but it is one of the things. And specifically when it is coupled with the same side that is more inferior, also more forward. So if you look up at your teeth, it's more forward compared to the other side. that is making you lean more and more toward the diagnosis of a fronto or nasomaxillary suture fracture. Now, how this is confirmed is with an updated x-ray, and essentially you can look at those sutures and you can see if there's more separation on one side compared to the other. And if you really want an accurate reading and diagnosis, you can do what's called a 3D superimposition. And what that is essentially you take your before x-ray and then you take the updated x-ray and they're placed over top of one another. And a superimposition is created, which basically just means that you can scroll from one to the next and you can see what's changed. So if you do a superimposition, for instance, you can see, oh, this side moved 3 millimeters and this side only moved 1 millimeter, or this came forward X amount and this didn't. And when you can see what movements have happened, it also helps you to dial in more confidently, what fractures may be the ones to look for the quickest. So this is what that looks like on an x-ray. Here you can see an initial x-ray, and here you can see a progress x-ray. And you might notice if you stare at these teeth down here, that on this progress x-ray, the right side is lower compared to the left side. And you can see that change all the way up here to the nasal bone, and you can see the floor of the roof of the palate here. You can see this side is lower than this side. So this entire essentially side of the maxilla has dropped down. And if you look very closely, and it's not super visible in this image, but you can see a little more separation here than you can on the other side. And I'll go through with you another image that is a little bit more clear. But what is clear in this image is you can see the right side is much more inferior compared to the left side. So this is an animation that shows that. So if you look here, you can see that everything else is stretching, but you're seeing a separation not only between the maxilla, but you're seeing a separation between the maxilla and the nasal bone right up here. And so this is kind of an exaggerated example of what that looks like, but that's a similar type of movement. You're going to see all the teeth on that side move, and you're even going to see this cheekbone move out. So if we do a 3D superimposition and you've continued to turn, then that's what you'll see. And if this happens and you continue to turn and turn and turn and turn, it's going to get worse and worse and worse and worse, just like you're seeing here. So here is what it looks like when both sutures are involved. You'll see here that not only the nasomaxillary, but also the frontomaxillary suture here are involved, and we tend to see even more downward movement when both sutures are involved, which makes sense because when we look at it, if this is involved too, there's less resistance up here. It's not connected as much, so it's going to drop down further. And again, you'll see that bending of the cheekbones there. Okay, this is an actual 3D superimposition, and this is what that looks like. So this was a doctor coaching case that came through just 2 weeks ago, a week and a half ago. So a doctor had sent me a before image and a progress image because they had noticed an asymmetry in the mouth, and they wanted to determine, what had happened and what they can do about it. And so you'll see here, if you look up here, the white is the initial, the blue is the progress. First off, you'll notice there's really not a ton of change over here at all. So this cheekbone hasn't really moved at all. We have gotten some bending of the bottom of the maxilla here. So you can see where that blue starts to come out and these teeth start to move out. But the vast majority of the movement is this left side of the face only. And you can see here this separation, clear separation between the nasal bone and the maxillary bone here. And if this patient were to continue turning, this would continue to go more and more out, and you risk fracturing other sutures the more pressure is left for those to deal with. But at this point, everything else had bended and remodeled, and these thinner sutures, again, the thinner ones are the ones that are more likely to fracture, are separated there. So you can look at that in a lot of different views. So this is looking from the bottom up, and you'll see here when we measured this out, this patient had 8 millimeters of expansion on their left side and about 1 millimeter of expansion on their right side. And so again, the more they turn, the more this is going to start to move forward and laterally. Now, one thing that was interesting, and you can get a little bit of a sense of this, but the symmetry that we actually saw on the intraoral photographs was not near as obvious as what you're seeing here. So when I was looking at the clinical photos, it was actually surprising how camouflaged this asymmetry was in his face. And that just was, kind of lucky for him, so to speak. It wasn't near as obvious as the female patient I showed you earlier. And so that's what that looks like from this view. Again, you'll see that downward movement. These superimpositions are so interesting to see. I still am blown away by what the bones of the face can do in a non-growing patient. This is the eye and this is the orbit. I mean, look at the bending and the change and the remodeling of all of these bones. Now, again, thankfully, none of these other bones broke. They just moved out. But to see how much an adult bone can grow, like my idea or understanding of human bone, adult bone, has really been shaped significantly. I always used to think of it, almost like wood and brittle and, really incapable of much movement. But, the more and more we see and understand how we can, turn that bone into something that really can be formable and moldable, it's really, really impressive what the human body can do. So the next fracture I want to talk to you about is a palatine bone fracture. And again, this is not as common as a frontonasal suture fracture, and neither of these are very common anymore. We saw a lot more of these traditionally when we were turning the expanders more aggressively. And before we had, the anchorage that we have now to provide more predictable midline splits. So this is the palatine bone and the maxillary bone. And what happens, unfortunately, is that if these fracture, it typically doesn't fracture all the way along the suture here. So it's not just like this piece of the maxilla separates and it's just this little piece of bone left behind. These fractures typically happen and they'll start here, but then when the bone is thin, they'll actually push up through here and they'll separate the first molar from the second molar, and you'll actually see the back part of the jaw being left behind and the front part of that side of the jaw will move outward. Now, the reason for this can be multiple, but if you have very thin bone here, and this is something I consult with patients when they send their imaging in, if I notice that the bone is very thin in these areas, one of the things that may be worth considering is an expander that has a tooth-borne component so that the second molar can be incorporated into the design as well. Because even though TADs are great for anchorage, and the FME is great because it doesn't rely on teeth at all, the FME TADs are placed in the maxillary bone exclusively. So this is further back than an FME is going to be placed. And so all of the force is going to be more forward. And if this bone is extremely thin and you have all of your anchorage forward and you turn too fast and or don't do something like a functional protocol, you risk fracturing here. So in patients with very thin bone, worth considering out of an abundance of caution, having a design that at least initially, while things are moving and getting started, incorporates both the first and second molar together as a unit so that you have, both force here and here. You're less likely to fracture between those areas there. Now, what does that look like when that happens? Again, very similar to the other fracture we saw, but instead of having the entire jaw move here, you see this first and second molar division here. This kind of breaks off as it shows here. And you'll get some expansion of the other side typically, but the majority of the expansion is going to be on the affected side there. When we look from the front, it's going to look very similar. Now, what can happen is that when you have this palatine bone fracture, you are more at risk of having a frontonasal or a nasomaxillary or a frontomaxillary suture fracture as well. So because all of this side is moving faster, it's putting more force on the other sutures. So if you have this and you don't notice it or you don't catch it early enough and you keep turning, you are going to be more predisposed to having this fracture as well. So these are things, again, signs you want to look for and be very aware and be in communication with your doctor about. So what does this look like when you see it in a patient? So this patient here you can see, and this is just sort of imagining where that suture would be. This was the design of the MARPE, and you can see here that it's not incorporating, in this case, the second or the third molar. So, had this been designed in a way where it was incorporating these teeth, the chances of this particular complication happening would have been much less. You'll also notice that if you're just looking at this, it doesn't look terribly off. You'll see a little bit this front part of the front part of the teeth is a little bit more forward on this side than it is on this side, but it's not off to an extreme amount. And part of that is that this patient is in braces. And so as those teeth and that piece of the bone starts to move forward, it's less noticeable because the brace is pulling on this tooth to bring it back. And so those changes can be less noticeable when braces are on. This is what that looks like when you see it in superimposition. And here, it's not really super dramatic yet, right? This is kind of the beginning stages of it. But as you go along, this starts to get more and more dramatic. And you can see here, this is what we're looking for on that x-ray. Look how paper razor thin this bone is. So that's that area of bone I showed you on the skull. And literally, you can almost not even see it. It is so thin. And some patients have bone here that's this thick. And so every patient is different. And that's why it's so important to know and understand the anatomy and to be looking at the anatomy on every single case. Some doctors ask me, like, do you have to have, this is called a cone beam or a CBCT, a three-dimensional x-ray unit in order to do skeletal expansion? And I said, well, do you have to? I mean, no. Doctors were doing it before, before many people had cone beams. And still today, doctors are doing it without cone beams. But I would highly, highly, highly not recommend that doctors do that because there's so much information that you won't have unless you have the ability to look at everything in 3 dimensions. So it's something worth noting. You can see also here that the sinus itself is fairly low. And so this is called pneumatization of the sinus, which means that, sinuses typically start out as solid bone and then over time they hollow as you grow. But some adults have pneumatization of the sinus, which really pulls this down as well. And again, there's not as much bone support here. And this is also coupled with the fact that the midline bone is quite thin. And so this patient really doesn't have what we call a lot of good anchorage. There's not a lot of good places to anchor the expander to this patient in order to get a good solid grip on the upper jaw to expand. So fast forward, and now we can kind of see here, look at the changes that are happening in this jaw. You can see this left side move forward, and you can see the front part of the maxilla and the upper part of the lip here moving as well at the same time. This is the nary, or the opening of the nose right here on the left side. You can see that changing. And you can see this division. This is where the first molar is. This is where the second molar is. And you can see this just shoots straight out. And everything else tends to remodel. All right, this is what that looks like from the side when we get to that point. So now you're starting to see more of that vertical change. So yes, definitely a split of the maxilla. Look how much the sinus just bends. So this is the bone of the sinus you can see just totally bends over. Again, my vision and understanding of how bone can move is vastly different now than it was even 3 years ago. So this is a superimposition tool, and if any of you are curious or you're in treatment and you want to learn more about how to create these, I mean, obviously you need software and whatnot, but there are patients out there who know how to do these. This superimposition was not created for patients. This demonstration video was created for doctors. But by all means, we need more people able to do these superimpositions because this is how we understand what it is that we're doing when we do expansion. This is how we learn. And so if you're curious about it and want to check it out, feel free. Or if you're in treatment and you would, maybe your doctor doesn't do superimpositions yet, feel free to send them this link. It's totally free. They can go on there. They can watch. It's about a 10 or 15 minute video walking them through step by step how to create these superimpositions from those 3D images that they're taking. So let's talk about management. So what happens if you do have a fracture that you don't want? The best thing is early intervention. You want to identify these things early. And really, when you have one of these unwanted fractures, in a way, you kind of have to give up on your skeletal expansion goals to some extent. You're probably not going to be able to expand, and you really want to back turn the expander as much as possible until symmetry is restored. or at least until it's restored enough that you can manage the bite, or your orthodontist can manage the bite, and you're happy with the way the face looks and the way the teeth look. And at that point, you'll leave it. You'll let things heal up, and then you'll finish the treatment with regular aligners or braces. Sometimes they'll use extra tads on one side, like for instance, if it caused a slanting of the upper jaw, you might place a tad on the side that slanted down and pull that side up. So there are ways to manage it, but if you don't catch it early enough and the maxilla heals completely, there really is no good way to fix this besides surgery. And even surgery isn't a great option because typically surgery is done from this level, about the bottom of the nose and down. But when we're talking about these asymmetric fractures, they extend all the way up to the level of the orbit. And it is very risky surgically, it's called the Lefort 3, to actually cut and move the entire maxillary bone up all the way into the orbit. And so typically surgeons won't do that. And so again, it becomes a very difficult to manage complication if this is not managed early enough. So definitely something you're gonna watch out for. The key, in my opinion, is prevention. So, you want to make sure, as doctors, we want to make sure that the expander is designed appropriately. We talked a little bit about that. And now, again, we're incorporating either a slow turn protocol or combined a slow turn protocol with a functional polycyclic or some type of a dynamic turning protocol. Because there's multiple types of expanders out there, after the diastema forms, I would avoid for a turning rate of over about a 1/3 millimeter per week. Okay, so you really don't need more than that. The only perceived benefit, I guess, of turning faster is that you finish turning faster. But again, that's a pretty low reward for the risk that you incur if you turn the expander too fast. You do want to watch expansion closely. So, obviously your orthodontist is going to be watching as well, but you want to be watching as a patient. So one of the things that I do is every single week that my patients are actively turning their expander, they are taking a remote selfie and they're uploading it to our remote monitoring platform. So every single week I'm seeing their smile, and I can compare it to the week before. I can compare it to 3 weeks before. And so if there's any asymmetries that start to form, we want to catch those really, really early. And then, of course, as doctors, we try to educate patients just like we're doing now so that they understand the signs and things to look for as well. So that is it for our unwanted fractures today. Again, if you were unaware, we do have online video consultations where you can go and you can upload your records, and we basically review those together. And sometimes patients utilize this in the beginning before they seek out treatment to see what the opinions would be. And to be very clear, I would say the majority of these consultations are not necessarily to become my patient, if that makes sense. A lot of these patients live in other parts of the country or other parts of the world, but they rather just want an opinion about their case overall, maybe some things that they can speak with their provider wherever they live about. To get the best experience possible and to have the best possible plan going into it. And then, of course, other patients utilize this when maybe they do have complications and they want to get some answers as far as, why that might be happening, and or maybe some help or advice on what to do about a certain complication if they experience it. So feel free to check that out if you find yourself in any one of those categories. So JP, I think we can open things up for questions now if we have some in the chat. That's a great question. So there may be some nuance to it, and there may be some exceptions. But in general, you want to back turn as much as you can, as quickly as you can. So I've seen patients back turn 15 turns a day. So when you're back turning, you don't have to be quite as concerned as when you're forward turning. And the reason is, the bone has just come from there. Now, what I would tell you is that don't, endure excruciating pain in order to do your back turns faster. I mean, if you're doing, even, 3 or 4 back turns, you're going to be moving pretty quickly. But what you'll probably notice is that you can back turn fairly quickly without experiencing a lot of pain or discomfort. And so really we want to try to back turn, as quickly as possible within reason. as much as you can, if that makes sense. Yeah. So typically we will do, of course, our pre-treatment CBCT, and then unless there's something that we need to see specifically, then we will do basically it's sort of a dual purpose X-ray. So if there's braces that are on the teeth, then we always take a progress image to evaluate the root positions and the bracket positions and things like that. Or we'll take an image after the turns are complete in order to assess the actual extent of the expansion that happened. So at a minimum, we have essentially one before, one after the turns are complete, and then one at the very end of treatment. So that's kind of the minimum. Now, if something comes up clinically and we have a question, then we take an image. So, I mean, it could be 2 weeks later. And X, Y, or Z happens, and we don't know. Like maybe we just, hey, well, let's take a look and see if whatever symptom or whatever you're experiencing or whatever we're seeing clinically, let's look at the bones and see what's happening. So we can always do more than that, but in general, routinely, we're going to have three: one pre-treatment, one after turns are complete, and one after the orthodontic treatment is complete. Short answer is only your ENT would know, if that makes sense. And here's the thing. So if it was truly only on the cartilage, then it would likely not have a big effect on your candidacy for expansion and or the quality of the expansion or the result that you would get or your likelihood to have fractures. The challenge comes when, as an orthodontist, I have no idea what was done surgically, whether that's previous jaw surgery, whether that's previous, deviated septum correction, whether that's previous turbinectomy. Like I can see some things on the imaging. It's like, oh, okay, it looks like that was cut, looks like that was moved, but I truthfully don't know exactly what was done. Anything that was done that affects the bones affects how those bones will respond to force. And so, a really, let me just go, and this is not a great example, but it'll at least give you an idea to illustrate this. So let's just say that during a surgery, you had this portion of bone removed, and this maxilla was just hanging out there. Well, as you can imagine, like if this whole portion of this cheekbone were removed, like this is a thick bone. When we're pushing here, this bone is pushing back or resisting the force that's pushing. So if this bone were gone, you can imagine that this side of the jaw would expand a whole lot more than this side of the jaw because the resistance was different. So the same principle applies. If you have surgery, it's going to change the resistance in some way. And that's where the unpredictability, nature of it comes. The other kind of factor that goes along with this is that not only can it change surgically a bone on one side or the other side, but it can also change this midline suture, how it's made up. So we explained at the beginning how when these sutures are unaltered, when they're not cut, when they're natural, they are mature in a way, but they're not fused. If I went through on an adult and I cut this suture and I cut this and I cut this and I cut this and I cut this and I cut this, and then I just do nothing, what's going to happen is all of these areas, instead of being mature and interdigitated and still dynamic, now what I've done is I've essentially created one solid bone. And if I were to go and try and expand that one solid bone, I would essentially have to go back and cut everything that I cut the first time in order to get that loose. And then still, it would be a question of, did I get everything cut exactly the same way? And anywhere I might have missed cutting is now an area that's still fused to the bone, and it's either going to cause a difference in resistance or it's going to break. And so this is why I am not a huge fan of surgically assisting anything when it's not necessary. Now, that's not to say we don't use any type of surgical assist. There are still very thick bone, adult male, dense bone, high resistance patients where we will do a piezo release of the midline palatal suture in order to reduce the resistance there and get this expansion process going. But I do believe at some point we'll have everything dialed in so much that we really won't need any surgical cuts at all. And even now, like I can't think of the last time where if a patient didn't want to do a piezo, I'll give it a shot. And again, it's like the worst case scenario is if you don't do a piezo and you have really dense bone, is that you might not split and you might need a second expander and you might have to go back and do another one. And if you're okay with that possibility, then by all means, like give it a shot. But when it becomes hard is when you've had cuts already and you didn't expand. And now we have essentially solid bone that we're working with. And so those cases become very tricky. And then, you know, that's even more complex. Like if you had a jaw surgery, maybe a double jaw surgery, and maybe the surgeon cut your maxilla in 2, 3, or 4 pieces. Now it becomes very, very unpredictable which pieces are going to move the most or the least. And the chances of unwanted fracture and asymmetry go way, way up. And so that's why sometimes like there's been a lot of post-surgery post-MMA patients that I will not recommend treatment for because of the unpredictable nature. Now, can you attempt it? Sure, you can. And in some cases we will if it looks like the prognosis is at least reasonable and the patient has expectations that are appropriate. They realize and understand all the things that we just discussed. But again, it does throw a wrench in the works, so to speak. Surgery does in general because it makes things, again, unnatural and less predictable. My opinion on this is, so in theory, you would think like, okay, well, it just needs time, right? It just needs time to you know, expand more, and whether I do like a functional turning protocol or just really slow turns, it's going to be the same result. That has not been my experience or what I see in patients. So what happens if you turn too slowly is that other things can happen that you don't want to have happen. Specifically, you can have the TADs kind of drag and bend through the bone. So rather than the sutures actually loosening up, what's happening is those TADs that are in the maxilla, you're turning so slow that this bone has the time to essentially pressure necrose, and these TADs can bend within the bone and move within the bone. And whereas if you're doing a functional turning protocol, there's not enough time for the TAD to essentially fail in some way. It's putting the pressure on the suture, and you haven't given the TADs enough time to fail or bend. So that is it'd be fun to have a conversation, but this is the question I would ask you, or whoever asked this question is, yeah, I understand what you're saying. So shouldn't we just cut everything here so that the upper jaw can come forward? Well, in a way, you answered your question by asking your question. So my question would be, well, if the upper jaw can come forward without cutting this, why would you cut it? So this goes back to this slide here, which is what is the most ideal expansion? And the most ideal expansion is the expansion that we would have had through normal natural growth. You know, obviously, if we're considering expansion, our growth was not normal to some extent. So you don't see kids with normal expansion have an abnormally larger separation between the pterygoid plates and the maxilla bone. So this distance between the back of the maxilla and the pterygoid plates is not artificially long in kids who grew normally. And when you cut this, two things. One, I haven't seen predictable additional forward movement by making those cuts, and they are fairly risky compared to the other cuts that you have. And you again can introduce some error if they're not cut exactly symmetrical. And if you don't split the first time, now you again have a suture that is not going to respond the same way that that an uncut suture would respond. So to answer your question, the most protraction I've ever seen have been in cases where these were not cut. And many of the complications that I have seen and failure to expand completely have been in cases where this has been cut. And so even though intuitively it makes sense, okay, cut this and the upper jaw should come forward, I would say go look at patients who have done it. Like look at their superimpositions and see if that's what you're actually seeing. I've looked at many patients who have done it. I've looked at many patients who haven't. And I have seen more protraction in patients who haven't that had good mobilization of the suture as the entire maxillary complex moves forward. Everything lengthens. It's not just here, it's not just here, it's not just here. The entire maxillary complex is lengthening and stretching and bending at all of these sutures versus trying to have almost an artificial separation of the maxilla from the pterygoid, if that makes sense. Another good question. You guys, honestly, you guys ask better questions than a lot of the docs that I chat with or lecture with. This level of detailed questions I seldom get even at my lectures, so that's pretty cool. I admire your willingness to learn and your dedication to understanding even the most nuanced aspects of expansion. It really is impressive, truth. I'll try to say it in a different way. So basically, you have two types of anchorage that you can have. You can have TADs, which all MARPEs have TADs, right? TADs are placed in bone, all right? But you can also have anchorage to teeth, which is like Partners Custom MARPE typically anchors to the teeth as well. And the teeth have roots, and the roots go into the bone. So essentially, the teeth are kind of like TADs. The biggest difference between TADs and the teeth is that the teeth, in addition to being like a TAD and being able to push on the bone, the teeth also have a PDL so that in addition to pushing on the bone, they also can move within the bone. But that doesn't discount the fact that they are a part of the anchorage system and part of something that applies force to this bone that helps it split. That's why, especially in earlier versions, but even still, the current FME protocol is piezotome release, even with the latest FME expander. And the reason for that is that, and this is for every FME patient. Again, that doesn't mean every FME patient has gotten a piezo, but that's the current recommended protocol. The reason for that is because having anchorage only on the bone through TADs does not provide as much anchorage as on the bone through TADs and on the teeth. And so if you are concerned about having a potential split between the palatine bone and basically having this fracture extend straight across and through this area here, if you have part of your anchorage system behind that area here, it's less likely to split between that area. So ideally, if they have third molars, if you have this and this and this, now you're pushing on the bone in this area, even if it's only a little bit. Or you could potentially even design a custom MARPE that has a TAD way back here, behind the second molar or in this area. Now, again, that's not typically what happens, and it's not what I'm recommending. Typically, if the bone is very, 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 very thin here, having a custom MARPE that at least covers the inside surface of these second molars is going to reduce the risk of having this fracture because part of your anchorage system is past that area that would be susceptible to fracture. So I hope that clears it up a little bit. So I'll try to simplify that question as much as possible. The middle part of that question was talking about which one should you do first. Well, in my opinion, just clearly because of the discussion we had about the unpredictable nature of expansion after jaw surgery, 100% I would do it before. So that part's like not even a question in my mind. I would never recommend a patient hold off on their MARPE or FME expansion to go get jaw surgery and then to come back to get that. That in my opinion is a very, that reduces the predictability and increases your chances of risk by a lot. But now the question of should I do MARPE and like a 3-piece or a multiple piece maxilla? In my opinion, the only reason, well, here, let me answer that a different way. What can get more expansion, a MARPE or a surgeon? And the answer is a MARPE, and that may surprise some people. And we know that for those of you that know the scolopendra case. All right, so there was 24 millimeters of maxillary expansion. A surgeon, can really only get about 3 millimeters ish, 3 to 4 millimeters of expansion per cut. And that's why you have multiple cuts, because what has to happen is, in addition to moving the bones, the soft tissue of the palate has to stretch or remodel or adapt. And so you have to have more places in the palate where that stretching can occur in order to get more expansion. So if we're purely talking about the expansion portion of your treatment, then most of the time, ideally, we will have the expansion completed before surgery. Now, one reason why you may not want to do it that way is if you don't want the other effects of MARPE expansion. So maybe, like your cheekbones, for instance, maybe you feel like they're too prominent and you don't want those to go out anymore and you need 10 millimeters of expansion. Well, you could either do it with a MARPE and consider maybe some sort of a cheekbone reduction. That's not a procedure I do. I don't even know how feasible it is. Or rather than doing a MARPE and a cheekbone reduction, you might just have the surgeon do their cuts, which are below the cheekbone, and expand the jaw that way. So there are some aesthetic considerations when you're determining whether to expand with a MARPE or to expand surgically. But in my opinion, if all of the movements of the MARPE are favorable, then I would all the time expand with MARPE before jaw surgery. And as far as the nasal benefits go specifically, I have not seen or any reliable data and or patients who are reporting that, you know, that they got a big increase in their nasal breathing after surgery that they didn't get with a MARPE. So patients who have done MARPE and jaw surgery, most of the nasal, most if not all of the nasal benefit that they receive is during that MARPE process. And then, you know, say they get jaw surgery, there's typically not a lot of increased nasal breathing benefit after that, if that makes sense. Yeah. Well, that's kind of two different things. So basically, can the teeth straighten out to some extent without anything on them, just by, you know, maybe the nature of the turns? And the short answer is yes. And the reason for that is between every single tooth are called interseptal fibers, and they're basically like bungee cords. And so that's the same reason, if you go back and watch the Jaw Hacks podcast, the original one I did, the new one's coming out, by the way, so stay tuned. At the end of this month or the beginning of next month, we're releasing another podcast with Jaw Hacks. But we talk about this, and the question was brought about because a patient asked, why do my front teeth go back like when I'm expanding? Like, I want everything to go forward. And oftentimes what's happening is that the jaw itself is moving forward, but because those teeth are connected by fibers, you have this tenting effect. And the teeth are actually pulling back because they're connected to one another, and you're stretching, and it's basically, you know, pulling it in. So that same effect can happen in between teeth. So if they're crowded, you know, you're expanding, and these fibers are working on the teeth next to each other to straighten them out to some extent. Now, is it going to be, you know, magical and straighten all your teeth for you? Probably not. And the slower you turn, the more of this effect that you'll have, because what happens is if you turn fast and just get a big gap between your front teeth, you'll have some of that movement of the teeth. But then what happens is the bone starts to harden in the middle, and eventually the teeth stop. It's almost like you stretch those centrals, the bungee cord between the centrals. And it's kind of like some of those bungee cords break. And so now, instead of, you know, having that elastic nature to come all the way back to here, it really only has the elastic nature to come to here. And so, like, that's as much straightening as you're going to get. And then you're going to have to work orthodontically to close the rest of the space. So, you know, going into the no diastema turning protocol, the key for this, in my opinion, is one, you want to keep the sutures active so that you avoid that problem with turning too slowly, right? You avoid that problem of the TADs bending and not really getting that bone movement. So even if you're doing a net forward turning protocol that is lower, I would couple that with a stretching turning protocol that is keeping the suture active. So you could potentially do, you know, 4, 5, or 6 stretching turns a day, and then maybe only a tiny turn forward, even a half turn, a quarter turn forward. That, in my opinion, would be better than doing just a quarter turn forward. And if you were to couple the stretching turns with very slow turns, you would be less likely, in my opinion, to get expansion that you don't want, because you're keeping those sutures active and you're not giving the TADs a chance to fail. The no diastema protocol typically involves aligners on the teeth as well. Or braces, but a lot of times with aligners. And those aligners are started essentially right when that gap first forms. And so you start to see a gap between the front teeth. You'll keep doing your stretching turns, but you'll pause and you'll get aligners fabricated. And then as you continue to expand, the aligners themselves are actively pushing along with the phenomena of the interseptal fibers, but a lot of it is the actual force the aligners putting on the teeth that's causing that diastema either to close or to not get as large while you finish the turns. Yeah, it's a good question, and truthfully, I don't know. I haven't really seen, or I don't have a good database reference to give solid information about that. The closest thing that I can refer you to, and I think Dr. Nuwaz mentioned this on his recent podcast with Jaw Hacks, when he was turning his expander, he was doing sort of, so let's just say he wanted to turn the expander, 0.3 millimeters a week. Rather than splitting that up throughout the entire week, he was kind of like doing jumping turns where he would do like 2 or 3 turns at a time and then not for a little while. And certainly looking at his 3D superimpositions, he got a lot of mobilization of the sutures. So in my opinion, I would almost lean more toward going the other way than going the way of spreading out the turns even more, maybe putting jump and putting just a little bit more force and then, chilling for a little while, let the bone do its thing. But from my standpoint, at this point, 2025 October, my belief is that having those stretching turns is the best way to get these sutures mobilized, and how much you turn forward is less important. But if I couldn't do a functional turning protocol, if I couldn't do stretching turns, then I would probably lean more toward some jumping turns. Again, the overall rate, we don't want to go fast. We don't want the overall rate to be fast. But there's something to, putting enough force on these sutures to allow them to remain mobile, that's really helping improve our results and decrease the chances of unwanted complication and fracture. So great questions. Again, all very, very good, well thought out questions. I appreciate each of you. Again, if you want to reach out, you can head over to vegasorthodoc.com. We can look at things together as far as your imaging and your case is concerned. But yeah, I wish you guys the best on all of your orthodontic journeys, wherever you may be at. And we'll look forward to catching up with everybody next time.
Yeah, that concludes tonight's call. Stay tuned for any future calls that we're going to be hosting. And yeah, again, thank you guys. Thank you, Dr. J, for this awesome live call. And it was super informative.
Yeah, we'll see you later. Take care now.
See you guys. Bye-bye.